Now, this is one of the very interesting CT scan of the chest. This is high resolution CT scan of the chest. And what we can see when we zoom in, there are so many findings in this. Let us start with the pleural effusion, because in this patient, the pleural effusion on the right side is very, very clear. It is always the left side on our right side and right side on the left side of our body. The, when we see from beginning, these are the lung borders which are crystal clear. These are ribs, we can see very well. These are all ribs. So just inside the ribs, what we get is all lung. So this is the concavity is there, which is perfectly fine. You can see here as well. The concavity is there. So this is all lung parenchyma which is present out there. But when we see, this is on the left, when we see on the right side, the rib is here, but there is so much of thing in between the rib and the lungs. So this is all water, because this is taking the shape of this concavity. So this is simply settling down on this area. So this is all free fluid in the pleural cavity. So this is pleural effusion, because this is the bone. This is how the patient is lying down on the back. This is the vertebra, which we can very nicely make out. This is the vertebra. So the fluid is getting accumulated around the lungs in the pleural cavity. So this is free pleural effusion, free fluid, which will move if the patient moves. So this is all free fluid, which we can see. This is pleural effusion. But what we see in the other images, when we look here, we know that this is free pleural effusion, which is accumulated here, but there is an accumulation of fluid in above here. So this is fissure basically. We can very nicely make out fissures, which actually divide the two lung lobes. So this is fissure, which you can see. This line is all fissure. This divides this lung lobe from this lung lobe on the left side, whereas on the right side you can see this is the fissure, which is very, very well demarcated. You can see this is fissure. This is very, very well demarcated fissure, which divide the lung lobes. So this effusion is along this fissural line, and it is against the gravity. If you can notice, the effusion is here, which is very well demarcated. So there is a discontinuation between these two effusion. So this is definitely a gravity dependent pleural fluid, which is free fluid in the pleural cavity. But this is against the gravity. Even the patient is lying down, the fluid is accumulated above, so it is not settling down. It means that this has to be loculated. This is blocked or clogged. So there must be a pouch of pleural effusion which is out there. So such pouches, these are very, very, very commonly seen in tuberculosis. So in India, one of the most common cause of such loculated effusion is almost always and always TB. Such patients should definitely undergo USG guided drainage of such pleural effusion, and it should be sent for ADA. It should be sent for gene expert. It should be sent for ZN stain. It should be definitely sent for gram-negative staining. It must be always sent for routine and microscopy, culture and sensitivity. And if the patient condition looks bad, or if the patient may, if you suspect resistance to a anti-tubercular medicine, then we should definitely send it for TB culture and sensitivity, because it takes more than 4 weeks for the report to come. So such fluid should be always sent for TB evaluation. And loculated effusion is very, very, very commonly seen in TB, though it can be bacterial as well. So this CT scan is showing free pleural effusion, loculated pleural effusion. I've shown the fissural lines, which are very, very obvious there. Other things which we can see is this patient is also having some patch. We can very well see that there is no any patch on this side or here, but here we can very easily see there is a patch, which suggests that the patient has active lower respiratory tract infection. That could be the cause for his pleural effusion. So such patches, inhomogeneity, very commonly may suggest active lower respiratory tract infection. Apart from this, what we can see, there are so many things like on this, we can see that there are so many small emphysematous changes. When we can see here, this particularly this, what is emphysema? It is an abnormal, permanently damaged alveolar unit. So that these small alveoli, they get damaged and they form a large uh, lesion or large airway unit, which actually does not help in oxygenation. That is the reason why they put so much pressure on the lungs, so that they do get shortness of breath, and they continuously commonly have hypoxemia, and the shortness of breath is almost always at a higher speed. So we can see such dilatations diffusely in the lungs, suggesting that the patient has underlying emphysema. We can very nicely make out here that there are so many small or dilatations of this airway unit, which are diffusely present in bilateral lung fields, suggesting that this is a patient of COPD. So this patient has COPD, pleural effusion, active lower respiratory tract infection, and as well as loculated effusion. That's all for today. Thank you.